it is due to one-way wall effect to the chest wall or parietal pleura. Causes are usual cause. Commonest cause is mechanical positive pressure ventilation in a patient with visceral pleural injury. Although you think that trauma patients get tension pneumothorax, commonest one is this. They get trauma patients get tension pneumothorax usually in the ICU after mechanical ventilation. Then the common causes are penetrating or blunt chest trauma in which parenchymal lung injury fails to seal and markedly displaced thoracic spine fractures. Those are rare but possible. And other common iatrogenic causes attempted subclavian or internal jugular venous catheter insertion. That is a very common thing in ICUs. This is occlusive. Wrong application of occlusive dressing after open pneumothorax also might be a cause, but it is also rare. And then the presentation. Usually, patient with spontaneous breathing present with extreme tachypnea and air hunger, and mechanically ventilated patients present with hemodynamic collapse such as tachycardia and hypotension. Then the presentations are especially examination. You will get tracheal deviation away from the site of the injury, elevated hemothorax without respiratory movements, and unilateral absence of breath sounds. Then, how do you diagnose tension pneumothorax? Patient comes with these symptoms and signs. Then, how do you diagnose? And the answer. Next.
Chest X-ray.
It is a clinical diagnosis.
That's the answer I wanted. You should not. Sorry?
Clinical diagnosis.
Yeah. Sorry?
It's a clinical diagnosis.
Sorry?
Clinical diagnosis.
It's a clinical diagnosis. You should not wait until X-rays. If you have ultrasound machine, portable ultrasound machine in your unit, you can do EFAST immediately, but you should not wait until the X-ray. If you have ultrasound machine, what are the findings in the EFAST? First one is lack of lung sliding. Lung sliding is there's back and forth movement between parietal and normal lung, but in tension pneumothorax there will not be sliding between parietal and visceral pleura. Showing a video. Can you see this? Can you see the movements here? Can you see?
Yes.
There's movements. This is normal lung. These movements are between parietal and visceral pleura. And then see this one. Here, there's no relative movement. Can you notice the difference? Did you see the difference? Here, there's no movement between two layers. Here, there's relative movements. Can you see? දැක්කද නැද්ද? Here, no relative movements. Okay. Then the other good finding is barcode sign in M mode. In normal lung, they have seashore sign. That is chest wall you see the chest wall as parallel lines, and you look as sands. And then the pneumothorax, you see barcode sign, several parallel lines. This is in M mode. And then the X-ray findings, you will get complete collapse of the that side of the lung and tracheal deviation and mediastinal shift. But you should not delay the treatment until you should not delay the treatment to obtain radiographic confirmation. Then how do you manage after diagnosing? How do you manage? You have to immediately decompress the tension pneumothorax, otherwise hemodynamic collapse might kill the patient. So what is the immediate intervention? What is the immediate intervention? You have to do the needle decompression. If it is not successful, you have to go for alternative approach like finger thoracostomy. How do you do the needle thoracostomy? When doing needle thoracostomy, you have to first select the safe triangle. In BTS guideline, they call it is safe triangle, and in ATLS they introduce the anterior axillary line and mid axillary line. According to the ATLS, you have to go between the anterior axillary line and mid axillary line above the fifth intercostal space. Probably, usually we go to the fourth or fifth intercostal space. But in pediatric, you have to go to the second intercostal space in the midclavicular line. Then after initial decompression, you have to insert IC tube for definitive treatment. Then the massive pneumothorax is accumulation of more than 500 milliliters of blood in the chest cavity. It commonly happens in penetrating wounds and rarely occur with blunt trauma. Okay, then how do you differentiate tension pneumothorax and massive pneumothorax? Usually in tension pneumothorax, trachea is deviated, neck veins are engorged, and chest is expanded and immobile. But in massive pneumothorax, these things are absent. Trachea is not deviated and neck veins usually not distended but rarely distended. And chest movement usually normal. And then is hyperresonant and massive pneumothorax is dull. This is the major difference between tension pneumothorax and massive pneumothorax. And breath sounds decrease in both. Okay. Then management. To diagnose massive pneumothorax, you have to establish large caliber IV lines, probably 14 gauge or 16 gauge IV cannula, and you have to infuse crystalloid. If it is a massive pneumothorax, how much of fluid you are going to infuse? What is the type of fluid and how much? Hello? You have to infuse you can infuse one up to 1 liter of crystalloid. Hartmann is the better one, and after that, after it's exceeding the 1 liter limit, you have to uh, transfuse uncross matched blood or type specific blood according to the availability. Usually, we can take type specific blood within 10 minutes, and it take around 30 minutes to take good cross match blood. So, depending on the availability, you have to transfuse blood after 1 liter. Otherwise, if you transfuse more fluid, like crystalloid, they will get problems, coagulation problems. Then, if you have facilities to auto transfusion, there's a specific machine to auto transfuse, you can collect those blood and retransfuse to the patient. After this, that is usually 28 to 32 French gate, and it is usually inserted in same place as in tension pneumothorax between the anterior axil line and mid-axil line. Then, what are the indications for thoracotomy? Massive hemothorax. These are MCQs.
The immediate drain is more than 1,500 milliliters, and there is more than 200 milliliters per hour for consecutive hours.
Yeah. Other than that, from the ATLS, persistent need for blood transfusion is also indicated. And other thing is penetrating anterior chest wound medial to the nipple line and posterior wound medial to the scapula. Also a factor where you should have a low threshold for thoracotomy. That is not an indication, but that those type of injuries should have a low threshold for thoracotomy. And in other conditions other than massive hemothorax, what are the indications for thoracotomy major trauma? When do you go for thoracotomy major trauma? Other than massive hemothorax, what are the conditions? Emergency or urgent thoracotomy, what are the indications? What are the life-threatening injuries according to the ATLS? Immediate life-threatening injuries. What are the immediate life-threatening injuries according to the ATLS?
Airway obstruction, tension.
Airway obstruction is not a immediate life-threatening injury according to the ATLS guideline. It is you can rapidly intervention for that.
Aortic dissection?
Yeah, aortic dissection. Sorry, aortic dissection. Actually, there's aortic dissection. Complete dissection. Patient might die at the scene. There's a partial aortic dissections are potential life-threatening injuries. In airway, tracheobronchial injuries. In that, you have to go for emergency thoracotomy. And when examining breathing, what are the conditions? Tension pneumothorax and massive hemothorax. Tension pneumothorax, what do? Needle thoracostomy or finger thoracostomy. And massive hemothorax, previously I mentioned that. Then in the circulation, What are the things?
Cardiac tamponade.
Cardiac tamponade. Cardiac tamponade usually we do aspiration, not thoracotomy. It's a cardiac rupture. It's true. It's correct. Cardiac tamponade is not an indication. And circulation wise, what are the immediate life-threatening injuries? Cardiac tamponade and cardiac arrest following blunt cardiac injuries. This is also immediate life-threatening injury. So in cardiac arrest, following, especially in PA, pulse electrical activity, you have to do emergency thoracotomy even in the emergency department or ward. Even in the ward, you have to do emergency thoracotomy, and you have to open the chest and do the cardiac massage. So that you should have some experience. So those are the indications. Other than that, as previously said, aortic disruption or dissection is also indication, and esophageal rupture. Those are the agent thoracotomy. Those are MCQs. Open pneumothorax. When the opening in the chest wall following injuries approximately 2/3 of the diameter rate of the trachea, it is known as open pneumothorax. So, when the wound is more than 2/3 of the diameter, usually effective ventilation is impaired, leading to hypoxia. To be a life-threatening injury, chest wall injury should be more than 2/3 of the diameter of the trachea. How do they present? They present with pain, difficulty in breathing, tachypnea, and you can obviously see the injury in the management. This is important. You take a opening thorax, you have to immediately apply three-sided dressing. You have to apply sterile occlusive dressing like Vaseline dressing. Vaseline dressing means it's not a porous one. Then you have to insert a chest tube remote from the wound as soon as possible. Subsequent definitive surgical cause of the wound is frequently required. Okay. Then another question. Previously, well, 20-year-old is brought to ED acutely short. ED acutely short of breath abnormality is shown in this X-ray. What are the abnormalities in this X-ray? Simple things. What are the abnormalities? This is a simple, easy X-ray. Show some specific signs in this one, but there are enough findings you can detect. What are the abnormalities? What is the diagnosis? Hello?
Left pneumothorax, left lung is collapsed, trachea is deviate to right side, and mediastinal shift to the right side also. And bowel in the, there is a right, left-sided hemidiaphragm rupture, so bowel also, part of the bowel also in the chest.
Diaphragm rupture. Why do you say so? This side. Look at this side. Sulcus. And this side. This is not a here it is obvious. This is called meniscus sign. There's no sharp costophrenic angle. Here also this is not sharp. There's a tension pneumothorax with some hemothorax. Hemo or effusion in trauma, it is usually taken as pneumothorax. Okay. Findings are complete pneumothorax, meniscal sign, not important. And the features of radiological tension. Mediastinum, as you said, mediastinum is inspiration. Here, hemidiaphragm is somewhat depressed. In some X-rays you can see it is flat. Features of tension are shift of the mediastinum and flat spaces. Here you can't see clearly. In a tension pneumothorax you have to see those findings. Then intervention is the key option to treat this page. Interventions, initially needle thoracostomy and followed by tube IC tube insertion. Then I think some of the students know about this question. Do you know? I showed this X-ray to some students in our surgical room. Did you see this X-ray previously? කතා කරන්න දැක්කම X-ray කලින් දැකපු කට්ටිය දෙන්නේ hello
No, sir.
okay. This is a 35-year-old man was involved in a motor vehicle collision in which his car was struck from behind and thrown into the wall of a bridge. He presented to ED complaining of back and leg pain. His vital signs are temperature normal and heart rate 120, blood pressure 156 by 95, it is high, heart rate high, blood pressure high, and respiratory rate 22. Swing saturation 95. He has left thigh deformity and open right tibia fracture. So see this X-ray and tell me the findings. In 30 seconds. guess කරන්න try කරන්න. And see this area. Is there any abnormality in mediastinum? Hello. Your mediastinum is wide, no? See the mechanism of this injury. Man was involved in a motor vehicle collision in which his car was struck from behind and thrown into the wall. It is a sudden deceleration injury. Now, with this mechanism, you have to suspect aortic injuries. Can you see the mediastinum widening here? You say it is a mediastinum widening. The diameter at the aortic knuckle level should be more than 8 centimeters. Here you can't measure that, but obviously there's mediastinal widening. What are the other extreme findings in aortic dissection or traumatic aortic disruption? Can you hear me? Hello?
Yeah. Yes, sir, we can.
Yeah. In traumatic aortic injuries, usually mediastinum is wide and aortic knob is usually obliterated. Here, aortic knob is obliterated, no? And trachea usually deviated to the right side. Here, you can't see that. And the findings are usually left trachea, left bronchi usually goes down. And elevation of the right main, elevation of the right mainstem bronchus and depression of the left main bronchus. Another things are left hemothorax. There might be a hemothorax on left side and rib fractures, usually first and second rib fractures. You have to see those injuries in such extreme. Okay, what's the reason to elevated blood pressure and heart rate in this patient? Can you guess? Usually in aortic traumatic aortic disruption, aorta damage near the isthmus. Isthmus is near the ligamentum arteriosum, because ligamentum arteriosum attach the aorta to the attach aorta to the body and rapid deceleration and mobile. That is the point where mobile and immobile parts are meet. So usual damage is there. In isthmus injuries, they stimulate the sympathetic nerves, so that because of the sympathetic stimulation, heart rate and blood pressure might be high in aortic dissection. If it is a total dissection, usually patient might die at the scene. If it is partial injury only, they will come to the hospital. So, do you have any questions to discuss other than these things? If you have any questions to discuss related to my area, that is MNS in me, I can discuss on next week. Okay, did you get anything from today's presentation?
Yes.
මොනවා හරි ඉගෙන ගත්තද?
Yes, sir.
Hello?
Yes, sir.
Okay. Shall we wind up here?
Sir, can you please send the presentation to us?
Okay, next week I will do the circulation. Okay, I can send. From next week I try to do circulation, fluid resuscitation, and head injuries. Okay. If you have question related to that area, please send to my Viber WhatsApp number. I can discuss those questions during the presentation. What is the possible date for you? Tuesday or Thursday? ඔයාලට දිගට මේ questions discuss කරන්නද නැත්නම් ඔයාලට class තියෙන ප්‍රමාණය වැඩිද? ගොඩක් අය කරනව නේද? SR ගොඩක් අය කරනව නේද? hello කතා කරන්න. What is the possible date for you? Tuesday or Thursday?